So, good morning or good afternoon, wherever you happen to be in the country and other countries. This is a webinar that is sponsored by the American Association for the Treatment of Opioid Dependence. My name is Mark Perino. I serve as the president of the organization. And today's webinar will feature Dr. Niraj Gandotra, who is the Chief Medical Officer for SAMHSA. This webinar is Understanding Telehealth Induction with Methadone and Buprenorphine in the OTPs. This is obviously under the guise of the new SAMHSA regulations. And these regulations were formally implemented on October 2nd of 2024. And a significant number of OTPs have raised questions about who can conduct telehealth admissions to the OTPs with methadone and buprenorphine products. So the webinar is our interest clearly in giving answers to the field about this, now that we are in a full implementation. And funding of this initiative was made possible under a prior Opioid Response Network sponsorship. And we obviously continue to work as partners to ORN and the American Academy of Addiction Psychiatry. So if you have any trouble joining the webinar or you're experiencing difficulties, please send a communication to Angelina Budia at atod.org. That appears on this screen, or you call it 201-218-8030. And if you typically listen to webinars through your computer, obviously you're going to click to make sure that your speakers are working and that your earphones are plugged in. So that should provide where we are. We'll have a question and answer once Dr. Gandotra has completed his presentation, which we figure is about a half hour or so. So there's ample time for questions, given that there are approximately more than 900 participants for this webinar. And we'll let you know the recording should become available by this Friday. And certificates of attendance are also going to be issued upon request by sending the email to info@atod.org. So thanks for joining us. Again, this is the topic of interest. Now, the regulations are quite expansive, as many of the people on this webinar know. And ATOD has been supportive of this because it provides a significant number of flexibilities to the OTPs, and that was the intent. Certainly that SAMHSA had underscored in the ramp up to these new regulations. We expect shortly that SAMHSA will release the guidance document which accompanies these regulations. Now keep in mind that the guidance document is just what it says. It provides guidance. It does not have the force of law, so-called, that the regulations do have, but the regulations really are it's a companion piece to the guidelines. So the guidelines will provide very detailed guidance as in addition to a question and answer. So with that, you can look forward to this. Even though October 2nd is the official implementation, SAMHSA is clearly aware that this is going to be an ongoing process. And we've done some webinars already. This one is specific to the topic of telehealth induction. So as I said, I'm going to get into the presentation with Dr. Gandotra. Dr. Gandotra serves as the Chief Medical Officer for SAMHSA, also has a background in addiction psychiatry and medicine at Johns Hopkins. He was the head of their addiction treatment services. I've known Jim for a very long time. I think he's very grounded and clear, and you'll find this out in his presentation. He's a thoughtful clinician as well, and given his knowledge of the regulations, I believe that you are going to get a very clear and broad understanding of how we actually can use this new opportunity. And it is an opportunity to admit patients to treatment. And so Dr. Gandotra is going to walk us through this process. And as I said, we'll open for the questions and answers at the end. So thanks for joining us. Dr. Gandotra, it is for you. So thanks again for being with us. I deeply appreciate SAMHSA's ongoing collaboration. I take nothing for granted, as people in my field know, and certainly our own board of directors. So thanks for joining us. Jim, it's yours.
Thank you, Dr. Perino, and I do want to extend thanks on behalf of our Center for Substance Abuse Treatment, Dr. Ingvild Olson, and our Assistant Secretary for Mental Health and Substance Use, Dr. Delphin Rittman. They both have expressed great admiration for the work that ATOD has done, and we view your organization as a strategic partner in the efforts to decrease overdose deaths. And medications for opioid use disorder are a mainstay for that strategy. I'm going to share some slides, and as you mentioned, while we'll be talking a lot about telemedicine, this really is in relation to how we began 2020 in the throes of the public health emergency. We really did see that we had to balance public safety, minimize diversion, and preserve a workforce that had been highly vulnerable during the time of the COVID-19 public health emergency. And what we realized through this process is that a lot of our fears with regard to telemedicine, with regard to take homes, with regard to what were long-standing regulations that were long overdue for revision, that the sky didn't fall. In fact, we found that telemedicine in general, patient satisfaction had gone up, provider satisfaction had gone up, no-show rates for outpatient clinics went down. There were lots of things that we saw that were not only indicating that telemedicine was a viable modality, but in reality, very few programs were at that time in March and April of 2020 really poised to deliver it. Now the landscape has changed. Telemedicine is here to stay. It is a viable modality that we hope to expand for the purpose of, quite frankly, expanding treatment. So with that, I'm going to just go through a few things. And these are more for just an overview for the audience. I know that many of them are already aware of most of the regulation. And hopefully more time will be spent during the discussion period. As you mentioned earlier, the compliance date for this revision of the regulations is October 2nd, 2024. And this was 20 years in the making that actually the public health emergency had prompted. And with regard to the revisions, we know that sometimes there are discrepancies between state laws and federal laws. And as a general rule, whenever there is a state law that may be more restrictive, then OTPs must follow the state law. So a couple things that with regard to admissions that I think are going to be worth mentioning. When we think about the time of diagnosis and the idea that someone needed to have 1 year of opioid use disorder to be eligible for treatment, that's no longer the case. They still must meet the diagnostic criteria for moderate or severe opioid use disorder or be in remission. We think that this was also important because we know the high risk of overdose for those who are not given medications for opioid use disorder is quite high. Of course, these should be adults or have written consent from their parent, legal guardian, or responsible adults. And of course, we have to have proper documentation of the admission decision and consent to treatment. Now, we did also expand, knowing what we learned from the pandemic in particular, that Practitioners, mid-level providers, such as PAs, nurse practitioners, and such, play a vital role in OTP operations. And certainly there were some revisions with regard to some of the functions that those mid-level practitioners could provide. But the medical director role must still be a physician. Now, a couple other flexibilities that are worth mentioning. We recognize that a lot of times, patients, when they come into treatment, they want to get their medication. They're shuffled through meeting a number of folks in that first 2 or 3 hours. And in reality, we want to establish the diagnosis of opioid use disorder, rule out contraindications, and determine the initial dose. This could be done through a screening exam and a full assessment, including all of the components of the physical exam, could be completed within 14 days. Additionally, the maximum dose per regulations is 50 milligrams. That's not only written, but also this was something that we wanted to highlight, which is that this dose can be exceeded as long as there's a clinical indication and that indication is documented. In other words, we were struggling with an idea of a one-size-fits-all policy, and we recognized that the practitioners really needed the discretion of understanding the patient in front of them to come up with the right dose. Now, the full assessment includes all of the similar components: the history, the physical exam, the psychosocial assessments, the lab, the treatment plan. All of that should be completed within 14 days. Now, when we think about telemedicine and how important it is to not only have the patient enter treatment, but reduce barriers to them entering treatment. One of the things that came to light was that telemedicine would allow for the provider, in terms of our regulations, to determine whether telemedicine would be accurate. We know in multiple medical specialties, telemedicine works very well, but there are some that it may not. And that's part of the question: that does the provider feel like the telemedicine exam would be adequate? And much of this assessment can be completed via telehealth. But there are going to be components such as the physical exam, drawing of serology testing, that will be needed to be done in person. So one of the things that we have also been in conversations with is with the DEA with regard to telemedicine regulations. I want to specify that our regulations are specifically for OTP practitioners in the OTP facilities. The DEA has jurisdiction and authority over the prescribing of controlled medications, but with regard to the dispensing of medications for opioid use disorder in the setting of an OTP, that's where SAMHSA's jurisdiction really lies. And we think this hybrid model allows the patient to attend the OTP in person, complete the components that must be completed in person, but the remaining components could be done via telemedicine. And as we were beginning this webinar, Dr. Perino and I were discussing, and certainly SAMHSA, in its attempt to try to create a one-size-fits-all, there are going to be nuanced questions that maybe aren't directly addressed in the regulations that will be forthcoming in guidance. And certainly use cases and questions that come up will be very, very informative to that guidance. So another question that had come up was really in relation to those who are not practitioners in the OTP space. What services could they provide to expedite the admission? And in particular, the screening process. As long as that was performed within 7 days of the individual's admission to the OTP, that establishment of the diagnosis and potential dose could be done outside of the OTP. And as long as the patient consents, Those records will be transmitted to the OTP and then upon review by the OTP practitioner, be integrated into the OTP's records. So that's an important lever that, let's say the person is in the emergency room and they get an evaluation done there and there's an examination that's performed and it's determined the person has opioid use disorder. Those findings, when they're transmitted over to the OTP upon review, could be utilized for the screening. Now, this can also go a step further. For instance, if there's a full physical exam and history completed by the OTP, by the non-OTP practitioner, as long as that is transmitted over and reviewed, that can also count within 7 days. And then when we think about serology testing, this was something that was really based on input from the field of how long should that value be contemporary and be used for. So within 30 days of that sample being drawn, that sample would still be eligible for the OTP to use as part of their history and examination. Another thing to mention is that, and this was always the case, that periodic physical exams of patients who are already enrolled should occur, and they should occur at no less than 1 year. Now, with regard to counseling, one of the things that we also wanted to ensure was that as barriers to OTP access was sometimes related to an individual's participation in counseling, we wanted to make sure, as part of the overdose prevention strategy, that access to these medications was not contingent on the involvement in counseling. Now, that doesn't mean that OTPs can't have policies that help incentivize counseling, but we did not want to make it so that a patient was denied medication. And many OTPs already had these policies in place. Now, we also do recognize that the durability of counseling and psychoeducation is very important for the person's long-term recovery. And these should be part of a collaborative spirit, the patient actively participating in their treatment plan, and ideally should include harm reduction education as well as recovery-oriented counseling. Understanding how important it is to also screen for many infectious diseases, hepatitis, viral hepatitis, HIV, and many STIs should be, patients should receive counseling on how to prevent that. We know that the rate of individuals with substance use disorder who have these infectious diseases is double the rate of the general population, and also that individuals with substance use disorder tend to contract these infections at a much higher rate than the general population as well. So certainly the OTP must either have services for these or be able to link the person to the appropriate treatment. Now, this is important because while we know that not every OTP will be well-resourced enough to provide every service, they should know where to send the patients if they do have any of these conditions. And this refers to also a number of other parts of the social determinants of health spectrum. We want to ensure that OTPs might be able to either provide directly or through referral, community resources, education, employment, case management. Many of these things are vital for the person's not only retention in the OTP, but their overall social capital building. We know that individuals, when they enroll in OTPs, they'll engage in other treatment-seeking behaviors, and it's important that we foster that. I know I'm preaching to the choir. I'm about halfway through, and I wanted to at least ensure that I covered these parts as well. Certainly, we want to make sure that through testing that compliance and diversion are both monitored. And we want OTPs to, of course, use tests that have been approved by the FDA. no fewer than 8 random tests per year. And this does not include also other harm reduction strategies, such as the use of fentanyl test strips or xylazine test strips. But it's important to note that that refers to drug sample testing rather than body fluid testing. And this is important designations, as those are not to be used in place of random drug testing. So take homes. This is another place where we really wanted to put the discretion of the provider at the forefront. It's up to the provider to determine the evidence of safety concerns, whether there are risks of diversion, can there be safe storage? And this is, an analysis that they'll make rather than strict adherence to a particular set of criteria that, was really time-based. And what we knew was a barrier to individuals staying in OTPs. So this will be limited by 7 days for the first 14 days of treatment, then 14 days after that. And then at the 1 month, there is complete provider discretion. Certainly educating the patients on safe storage, transport, documenting all of that is going to be still part of the routine. But again, there are states that have limited the number of take homes and limited some of the other discretions. So it's important that OTPs follow their state laws. Another common thing that was mentioned was split dosing on day 1, in particular for pregnant patients. Allowing for split dosing is really a way to help manage some of the opioid withdrawal symptoms that may occur early in the induction period. And then, of course, OTPs reach capacity. And there are times where we don't necessarily want to turn patients away. We want to make sure they at least get the medication. So the ability to offer interim maintenance for up to 180 days if the comprehensive services are not available. I know many OTPs, their counselors are capped, and it's unlikely for them to be able to admit on a rolling basis at making full comprehensive services available. But we needed to keep the patients in there. Of course, there are going to be special populations and considerations for them as well. Another interesting point to make is that mobile units, the moratorium on that has been lifted, certainly to reach other isolated or underserved populations. This is another modality that can be utilized. I know we're talking mainly about telehealth, but it's important to recognize that these are going to be tools in the toolbox that may be appropriate for some, but not all OTPs. So it's up to the OTP to determine which are best for them. Now, when we really think about the bottom line here for this slide is that we want to have documentation of the decision. And it's important to recognize that the decision is going to be at the discretion of the provider. And providers are certainly well equipped to make those decisions. What we wanted to provide were some guardrails for what they may want to think about. But it's important to recognize that each one of these decisions should be on an individualized assessment and an individualized progress note, not the boilerplates that we had utilized, because quite frankly, we were able to, because everything was set by time and treatment. And now with that discretion, we want to make this an individual determination of the risks versus the benefits of the take homes. And of course, we want to comply with state laws there as well. So why did we consider all of these changes? I think this was from the field. We heard from the field that the regulations needed to be more person-centered. We needed to promote trust and recovery and patient engagement. We recognized that, OTP services should be flexible, grounded in evidence. And the evidence suggests that not only is telemedicine here to stay, and the diversion rates did not go up, overdose rates did not go down, overdose were effectively addressed with treatment expansion, with harm reduction services. We also have to understand that, sitting in Rockville or Washington, D.C., we don't know what's best for your patients. You know. So we trust that you'll be able to create the appropriate plans of care that are person-centered and effective. And the bottom line is that this is a chronic condition. And as I recall, one of my mentors used to say, sometimes this condition gets very loud, sometimes it's very quiet. But as a chronic condition, we have to be prepared for both. And it's important that we utilize not just the evidence-based practices and skills, but we also change our language to ensure that patients are not turned away just by the language we use. And this really speaks to the stigma, the mark of shame that sometimes patients receive upon entry into these clinics. I used to say that, and this was reflected from patients that would tell me that, coming into the treatment center was for the first time was the best day and the worst day of their lives. The worst day because this was now a problem that they couldn't solve on their own. And we would reflect back how it was also the best day, that because now they have hope. Something got them through their door. Whatever resources they had to scrape together to get in, then we were going to help them from that point forward. And that will speak to whichever setting the patient presents in. And this is where, telemedicine is probably has its greatest strength, is that now they don't necessarily have to walk through the door to initially engage into treatment. They will have to get there for their medication, of course, but the idea that that first interaction could be through a video visit or through a different facility and a referral means that there are going to be more open doors. So we hope that you'll see more patients. Patients will be retained longer in care. We expect that we'll expand the reach of the OTPs through mobile units and telemedicine. And, when you modify some evidence-based strategy for your particular population, we want to hear about that too, because we like to echo successes. We want to ensure that we amplify them and amplify those strategies as well. And OTPs may become medical homes for many patients, where they integrate primary care, infectious disease treatment, and a number of other health services. The most important thing, though, is that, patients, when a problem is identified, then a plan is created. Doesn't mean that everything has to be run through the OTP, but at least if it's identified there, then the appropriate linkages for integration can occur. I know I've been on the soapbox for a few minutes, and you probably have lots of questions. So what I'd like to just mention is that if anyone wants to read the hundreds of pages, you can take a look at the Federal Register. But we were very, very intentional to not make the final rule as complex or more complex than it needed to be. So it was written by clinicians. It was written by staff that actually sees patients. It's written by our compliance officers that review the accreditation body's reports. It was written by individuals who actually recognized that we did not want to make this more confusing. That said, while our guidance will come out and have very specific examples, you can look at our web pages to see where we have some FAQs. You can also email provider support at SAMHSA, hhs.gov for non-clinical questions about the regulations. And we also have our Division of Pharmacological Therapies that may be able to answer some specific questions in the meantime. The most important thing is that while we try to make it as inclusive as possible, we understand that there might have been some blind spots, and we certainly appreciate when those are brought up as well. And with that, I would ask that you all take a look at all of our resources. SAMHSA's primary role is to give grants, provide technical assistance. We have both of those available. And for those individuals that are, worried about the patient that they see at 4 p.m. and the patient says something that worries them, you're not alone either. Certainly 988 and the Crisis Lifeline Toolkit is important for all practitioners to be aware of. As we know, the high comorbidity of mental health conditions and substance use disorder. You'll be able to utilize this. I can say I've personally tested this with patients. They have great follow-up with the patients, and I found that the patients not only respond well, but the responsiveness of the staff of those respective states providing the lifeline services has been phenomenal. With that, I think I'd like to give as much time as possible to questions. So happy to have those moderated, and we can run through some of those.
Okay, so Jim, thank you very much. I appreciate the fact that, while the focus has been on the induction, that you did broaden to other aspects of the regulatory issues. And as I indicated at the beginning of this webinar, we should expect SAMHSA to release the guidance document, which at last count was about 150 pages of length and a Q&A. And it does provide very clear guidance, so that is helpful. And I think also you should be aware that our association will release a report on barriers and questions about mobile van development in the next 2 days. And I've sent a draft of that over to some folks at SAMHSA. And Jim, I'll get that over to you by the end of today as well. And it does provide interesting questions and barriers, probably the most significant being Medicaid reimbursement or the lack thereof for mobile vans. And again, in an acknowledgement of SAMHSA's leadership, SAMHSA was very quick once the DEA amended its regulations in 2001, I think within several months, to produce documents that went to the field and the states that indicated what services can be provided to the mobile vans. Medicare really was quick to respond, to provide guidance from the CMS Medicare point of view about what could be reimbursed through Medicare. Medicaid has been a bit slower, let's say, but I would suggest and certainly will work with SAMHSA and the folks at CMS to try to motivate Medicaid directors in the states to move this, especially in the mobile van development. So we do have a number of questions, Jim. Let me start with the question that has apparently beguiled a number of people. Do physicians have to see a patient within 14 days of admission for both buprenorphine and methadone if a mid-level does the initial admission?
So to answer that, I do want to specify we're referring to a mid-level at the OTP.
Right.
Yes. At that stage, the mid-level has provided the has done the full assessment. I would say, it would depend on the state with regard to if the state requires supervision of the mid-level provider. But from the federal standpoint, if that mid-level provider is part of the OTP, then the physician does not need to. But the state may have a more restrictive policy when it comes to supervision of mid-level providers.
Okay, thank you. Next question is, what happens if the telehealth induction for methadone and buprenorphine is initiated, but the patient does not actually show up for either the physical exam or have lab tests performed within 14 days? And how does this affect the admission into the OTP?
So this is something that does happen where A lot of our patients may not have organized lives enough to make it back. Sometimes there's things that happen that keep them from coming back in within those 14 days. Um, as far as things go, if you would have to restart the process. I would assume that when you say that you've initiated methadone or bupe, you have not given 14 days worth of meds. So at some point, there will be touch points where the patient will have had to come back in to get more medication. And at that point is where those examinations should and labs should be drawn at that time. Ideally and operationally, that's how I would approach that.
Okay, thanks again. How would you describe, Jim, how the OTP can admit a hospitalized patient being discharged to a skilled nursing facility? And can the review of the full physical count, I guess as a patient in the OTP, count as a full admission, not just a screening admission?
Okay, to make sure I understand the question. So a patient is in the hospital, they're going to a skilled nursing facility, and at some point after that, they're to be admitted to an OTP.
Right.
And can the physical exam that is done, I'm assuming, at the skilled nursing facility count towards towards that process, or for that matter, the hospital? It would have to occur within a certain time period. That is the first part of that. I would say, with regard to no more than 7 days prior to the OTP admission, and the person performing uh, that assessment, if they should be a licensed practitioner, and um, they should be able to have those written results and narratives of the exam, as well as available lab testing, transmitted to the OTP, and then verified by the OTP practitioner.
Okay. Uh, this next one goes into a direct transfer from an OTP. So this is about a continuation of care. So if the prior OTP conducted the physical exam and laboratory tests and then transfers the patient into the new OTP, should the new or receiving OTP conduct a new physical and lab work at the time of admission? And I know this is a time-related issue as well.
That's correct. If the information is transmitted over, um, still the idea is that it has to be timely, contemporary. The idea that, and if they're an OTP practitioner, that somehow they have the ability to understand the nuances a bit more. Uh, that's certainly something that we believe in. Uh, but still, this premise of being contemporary is the most important part. That physical findings change over time, lab findings change over time. So, with regard to the examination, we still want this to be within 7 days.
And if you could explain again what the non-clinical staff can do in performing intakes and assessment activities, and are there limitations to the activities that the non-OTP clinician can provide?
So, um, this is sometimes a bit more complicated when it comes to staffing. Um, it's important that the OTP practitioner uh, really have oversight over all of the processes that are taking place. Um, the idea that there can be some part of an in-person nursing assessment or counseling that can occur. That That's certainly okay. I imagine that, no, the OTP practitioners, such as mid-levels and physicians, are not necessarily doing the vital signs. They're getting that information from either the nursing assistant or some other staff. Counseling is probably providing, counseling services are also probably being provided, as well as some of the history that's taken during intake. All of that information should still be reviewed by the OTP practitioner to ensure that it's accurate. And as long as they have the information necessary to complete the intake, that's the important part. But it is ultimately the practitioner that is responsible. Now, I want to be clear that that doesn't mean that a person, let's say, I'm going to just call out a nursing person, a nursing professional, such as an RN or an LPN, is doing the physical exam, and that counts. That's not what I'm saying. Um, I'm referring to perhaps some of the screening questions, some of the questionnaires that are given upon intake that can be filled out by the nursing staff or the counseling staff and the intake staff. But all of that information still must be reviewed by the practitioner who's doing the intake and the physical exam.
Also, a point I'd like to make, and this may appear obvious to a number of the people joining us today, that all of this has to be very carefully documented in the patient's medical record. And especially the fact that the new regulations do provide greater flexibilities to the OTPs in admitting patients at a faster rate with less of an impediment. But remember, that means with greater flexibility comes also potentially greater liability. And in this particular case, you have to have the documentation in the medical record. This has always been the issue since the inception of OTPs in the 1960s. That has not altered. So, I'm sorry, Jim, you want to say something?
No, please continue. I couldn't agree more that with greater discretion, there is potential vulnerabilities.
And,
And,
and
and I will also state one other thing. It's important to recognize that these are individual decisions, and ultimately they will be judged by other experts in the field if there is ever circumstances that are called into question. Uh, it's important to recognize that thoughtful consideration was made with every decision, not necessarily always that it's the correct decision in someone else's eyes, but that a thoughtful consideration was made during during that deliberation and ultimate decision.
so now we get into split dosing.
Mhm.
And the issue here, there are two parts of this question, Jim. The first is, does split dosing require at the present time an exception from SAMHSA via the SMA 168? And then part B of that question is the split dosing for non-pregnant patients to be impacted by these new regulations. So those are the two.
So split dosing no longer requires an exception. Certainly, our Division of Pharmacological Therapies can answer specific questions with regard to the regulations, and I would ask participants to certainly ask them specifics. But split dosing is allowed on day one at this point, and it's the provider's discretion as to whether it's reasonable or not. Pregnancy is one of the indications, but it's not the only indication for split dosing.
And I think that, obviously, and it's based on what the patient is presenting. But again, I want to underscore what Jim has said, that the concept of split dosing is clinically applicable from time of admission. It's determined by what the patient is reporting, obviously what other medications are being used by the patient that might accelerate the metabolism of methadone. And this is in a non-pregnant patient as well, because obviously the use of other medications, which accelerates metabolism, is its own separate medical area. But again, that assessment is made as even the patient is being inducted into treatment. But again, the clinician has to take care because this also happens during a dosage increment period as the patient's being newly admitted to treatment. And again, the complicating factors are other drugs the patient may use at the time of admission or may continue to use, particularly with fentanyl and methamphetamine. So as you're going through the dosage building up schedule, you want to take great care in determining what take-home medication the patient is receiving. And that's, again, that issue of clinical assessment related to medical record documentation and just to contain incidents of professional liability. All key components here. So, Jim, will the psychosocial assessments, either at annual or admission, be able to be conducted and billed via telephonic reimbursement?
That's a payer question, depending on the state and the payer. That I wouldn't be able to answer specifics about that. That'll be for the payer to determine.
I don't know if you can answer this question because I certainly can't. Do you anticipate that the new administration might alter the new regulations or otherwise delay their implementation?
Yeah, I don't have a crystal ball with regard to that. I will say these regulations are now in effect. It would take new regulations to change them at this point. And we both or all know the regulatory process is a long road. So I would say at this point, we should expect these regulations to remain in effect.
Yeah, I would think so too. So there's a question in general about take-homes. So do you suggest providing patients with take-home medication if they're using other illicit drugs at the same time? And the practitioner here is expressing concern about the diversion of the medication if the patient is actively using other illicit drugs.
So this is a clinical question. It would be determined by a number of things. One of which is how stable is the patient's home life? Do they have a place for safe storage? Is there and what is the substance in particular that they're also using? Some states, for instance, have very different perspectives on cannabis use versus other states that may be far more restrictive. So the idea that this is a decision that the urine toxicology is only one part of the consideration for take homes in the overall spectrum of the patient's stability. Obviously, if a patient is showing up drug affected, you're going to be very cautious in giving them take homes. However, there may be circumstances where a person's toxicology is positive, but other aspects of determining stability demonstrate that it may be okay to give them some number of take homes. This is an individual clinical decision, and I would stress what you mentioned earlier to document the considerations that were weighed when that decision was determined.
Right. So there's a question, we've alluded to this earlier, Jim. When do you anticipate the SAMHSA guidance document to be released? And this question is based on some states apparently may be delaying the adaptation of the new rules until the guidance document is released. And there's an important distinction here that the field may not know, that the states need to be in alignment with the SAMHSA regs, while the OTPs need to be in compliance with the SAMHSA regs, because the SAMHSA regulations are specifically directed towards the OTPs in terms of a regulatory compliance. So anyway, you get the idea. I don't know, Jim, if you can provide that sort of guidance about when these documents are about to be released.
So I can say they certainly have been drafted. We have been in talks with various state opioid treatment authorities to gain their perspectives. This is an ongoing process and clearance. I am not actually able to give a timeline of how quickly the clearance will occur. We are shooting to get this done uh, very quickly in weeks rather than months, but I can't speak to an actual release date.
And what will be expected of the OTP if the patient does not complete the required admission regulations within the 14-day time frame? So what should the OTP do in such a circumstance?
So this is also another clinical question that if if you're saying that the patient had some extenuating circumstances to why they were not able to come back into treatment within 14 days, we certainly would want documentation of such. While we don't want patients denied the medications for opioid use disorder, that is an important, when we think about carrots and sticks, the idea that, at some point an admission would need to occur. Uh, I can't imagine a circumstance where it's a patient that you don't know, that you're not seeing a few times within those 14 days. And if something has occurred that's prevented them from showing up, then you have documentation uh, to support that. If they're in the hospital, if they're incarcerated, at which point you complete it upon their return.
So it's an interesting question, I think more philosophically based. So if the regulations are patient-centered or person-centered, and the provider is making the determinations about take home, is there some inherent conflict with that? So the OTP is accountable for making take home decisions, as you said. How does that fit into the person-centered paradigm?
Yeah, that is a very valid point, and certainly it does also have its roots in how comfortable the provider may be, and with regard to the number of take homes, and there is going to be some discrepancy in terms of one provider versus another's interpretation of stability based on various criteria. What I mean by practitioner discretion is that the practitioner is expected to not just look at toxicology and time and treatment, but all these other aspects as well. Does the person have a job? Are there, responsibilities that are keeping them away from the OTP? Are there other aspects of social capital that can be good guardrails to ensure that diversion is minimized? Is there a community support person identified that's already engaged in treatment? These are things that might speak towards giving a patient more take homes. So these are things that the patient would potentially be providing information upon the provider to give greater consideration for. But again, it is the provider's, when I say discretion, it's also their liability, their vulnerability. And that is something that still rests with them. We believe that these regulations have moved forward towards a more patient-centered approach. There's many people who still say that we haven't gone far enough, and there are probably still some who say we've gone too far. But in reality, this is a process that moved us forward with regard to being more person-centered, probably not as far as some would like.
And I think that's probably the case because I know this is going to be an evolving issue and there is no perfect response because, again, when you're providing take-home medication, and if you're the clinician at the OTP, you have to consider, as you said, a number of perspectives because if something goes wrong with that clinical decision, the OTP and its personnel are held accountable. And that's the simple truth of the matter. So a question that's come up is, what is the best platform in setting up the medical director to be able to conduct telemedicine for intake on days when the practitioner is not in the office? And I don't think you can answer this. It's a question then that says, would it be covered by Medicaid or Medicare? And that's again a payer question. So I guess I'd focus on the first part of this.
So if you don't mind, can you repeat the first part again? What
Sure.
would be the platform? Go
Yeah,
ahead,
what would be
please.
the platform to set up for the medical director in order to be able to conduct telemedicine for intake on days when that practitioner is not in the OTP?
So I would first of all say that, this will be determined by also the resources that the OTP has available. But the idea that the the medical director would be able to perform a screening, perform a determination that the person has opioid use disorder, that uh, the person also would benefit from the medication for opioid use disorder and a potential dose. This would require, at the very least, an audiovisual platform where they could certainly visually observe how the patient is presenting and also make some notes about their appearance. While this would not be a full physical exam, that could be enough for them to at least make the determination that the person has opioid use disorder, would benefit from a medication, and start a dose. An audiovisual platform, there are many. I can't recommend one over another, but that would be considered to be at least the minimum.
Okay, so I don't know how you can respond to this one, but the suggestion apparently by some in the field is that if an OTP is very conservative and doesn't provide take-home medication, or now in the lack of specific take-home criteria in relation to the number of take-homes providing, the question is, how do you prevent OTP shopping? In other words, one program is going to provide more take-home than another. And I guess the question is, I don't know if the regulations can do anything that serves as a preventative for that.
Yeah, that's a great question with regard to, how markets may be shaped by this. I will mention a couple things. One is the majority of patients who are coming into OTPs are coming in because they are tired of dealing with opioid withdrawal. They're concerned about where their life is headed. And more likely than not, they also just want to feel better. So if patients, as they talk to each other, recognize that one OTP may be at a higher or taking a more restrictive approach than another, yeah, there may be a shift of some patients. I could imagine, though, for many markets, major cities in particular, there's generally no shortage of patients. One piece to this. The other piece is that patients do want to do well. And if there are programs that are potentially getting that reputation of not providing care, that will shift patients away. But to answer your question, I think that this is one of those consequences that we will have to examine as we gather more data about this.
Yep. So with regard to laboratory testing and the results, And the question hinges on that the patients can refuse testing, and that admission to the program and continued dosing is no longer contingent on completion of laboratory work. As long as the medical director documents the rationale for this in the patient's medical record. So, Jim, what this really hinges on is in this new patient-centered approach, and I've had the opportunity to read the draft guidance document, which I know that guidance document does get into this a bit more than the regulations do. So, in answering this question, what guidance can you provide?
So the idea that some patients may refuse at some point doesn't mean that you're going to just blindly give them medication day after day after day without some contingency. Um, I'm reminded of times where, these might be things like changing the dosing time so that the patient gets dosed later in the day as a way to incentivize them to complete these other tasks. Um, but what we don't want is for the patient to be not denied the medication. But certainly there are ways to, I'd say, incentivize the patient to complete those tasks. They would get earlier dosing times. They'd be eligible for take homes. You can use all sorts of contingencies to try to get the person to provide at least at least what we consider to be the minimum standard, which is you need to know how the patient's health is. And explaining that to them is probably one part of this as well. I want to be very clear about that because, when patients refuse this, more often than not, it's because they weren't oriented uh, well enough about the processes. And the idea that they're refusing this on intake, that's probably an orientation issue rather than them concealing some other use. Because we would expect a person with an opioid use disorder, they might be positive for other substances as well. When it comes to serology for, infectious disease, this is really the place where counseling and education is going to be at the forefront to have the patients properly understanding the rationale for why it's being asked of them, that this is not something that or I don't want to even suppose what might be in their head, but having the proper education as to why it's important is also part of that orientation.
And it clearly we've commented on this already that this does provide, an interesting challenge to how OTPs are managed. And I think in this case, I don't expect that there would be many patients who would be refusing laboratory testing because it's in their best interest. And of course, it is up to the OTP to explain all of this to the patient because that happens. So in this, there's another case of a non-ambulatory patient who's transferred from a hospital to a skilled nursing facility or back to their home for home care, but the patient needs to be admitted to an OTP. And how can the OTP go about conducting a full assessment if the patient is unable to report physically to the OTP?
Well, I mean, the medications will eventually, well, at this, I will say it a couple different ways. The first way is that non-ambulatory, I'm going to use the example of the person's in a wheelchair. They will have to come to the OTP eventually. There's medical transportation, there's ADA compliance regulations for the actual physical building for them to enter. There can be transportation services provided. The person will have to show up to the OTP to get their medication at some point. So I would say with proper planning, that should not occur, that the person's unable to be admitted to an OTP. There may be a question about the time frame of getting all of that scheduled, but but I would imagine those are very few exceptions. If the person already has resources to get into a skilled nursing facility or to be discharged from the hospital, this is something that should be, you know, uh, that should be planned out on the front end rather than jumping at the last moment.
Right. And that would make sense because ultimately the opiate treatment program is an outpatient facility.
Yes.
It is not geared toward inpatient or residential care, just not.
Yeah.
So there's a question here about split dosing. Under the new regulations, the question is it true that peak and trough testing is no longer required to make split dose determinations?
So this is a clinical decision based on the patient's presentation. Um, if the clinician still determines that that is necessary, please do it. I think that there probably are special populations such as pregnant patients that maybe it's not needed as the data has shown over several studies that many pregnant patients benefit from this. But I wouldn't dissuade anyone from getting peak and trough levels to help standardize the patient's dose. To help from the standpoint of clinical information, you should get those.
So there's a question about methadone induction that normally includes getting an EKG and then asking the patient if they have a history of cardiac issues. I guess the question is, when is the OTP clinician suggesting that methadone is contraindicated based on heart arrhythmias? And this goes back to the old reports of cardiac induction in the OTP or the OTP patient.
So this is squarely a clinical question with regard to um, when when should you get an EKG? Um, and I will first preface this. There are a number of medications that can prolong the QT interval, which is the primary measurement that we get when we have the EKG done. Um, and I would I would rely on the clinician to obtain a thorough medical history. If there's a history of any heart conditions, arrhythmias, and such, that would be something that, would make a EKG clinically indicated, probably at induction. Someone is, young and healthy, they can use their clinical judgment with regard to when they should get an EKG. Some have some dose parameters. So when their methadone dose reaches a certain point, they'll get it. Or when the person has a new medication added that might affect um, conduction. So those are things that I would say are squarely in the clinical space.
And there's a question about why methadone is not included on the list of medications for either PDMPs or CRISP when the OTPs are checking for dual enrollment. And there are a couple of answers to that, but that's the question to you.
So some states do have that. Many states still do not have them listed in the PDMP. I think that states are trying to work out their um, their own interpretations, uh, protecting patient information. Most states have a registry that can be checked for dual enrollment. PDMP checks are typically done anyway upon admission to OTPs. Um, Ideally, we'd like to have a standard system that any OTP can log into. Probably not there yet from a technology standpoint. Um, but this is more of a state issue rather than a federal issue.
Right. And PDMPs are really controlled by the states, not the federal government.
Correct.
And also, the issue here is about confidentiality. So when methadone hydrochloride products are prescribed for pain management, they would be
Mhm.
incorporated with a PDMP.
That's
However,
correct.
if the methadone is administered at the OTP would not be providing methadone to the PDMP. And that is an issue even under current confidentiality regulations. So there's the question about this is from a provider group, obviously, Jim. So it says we're experiencing states interpreting the audio only telehealth exemptions for methadone admissions and the methadone admissions physically different than would appreciate, and they'd appreciate clarification on this. Because apparently there seems to be some confusion on what the medical providers can do with regard to OTPs versus community-based medical practices in terms of the audio-only telehealth issues.
So let me make sure I understand the question. Trying to read it as well. Um,
Well, I think the question really goes to the issue of, I think, separating an audio-only telehealth component. Now, the regulations are pretty clear. If you're admitting a patient with methadone, an audio-only component is insufficient.
that's correct. Yes.
So I think that goes to in my interpretation, it goes to the heart of the question that an audio-only component is specific to buprenorphine induction. It is not
That's right.
on induction.
Yes, that's right. And that's why I'm trying to figure out where is the confusion about this. Um,
Right.
so, community-based providers who are providing buprenorphine for opioid use disorder, that falls via telemedicine, that falls under jurisdiction of the DEA and believe the Ryan-Haight Act when it comes to telemedicine and the exceptions that were provided during the public health emergency, which run through the end of this month, end of December, excuse me.
Right.
And but OTPs, this is our our jurisdiction, and it's been determined as far as buprenorphine goes that audio only is sufficient in situations where the patient refuses or doesn't have the technology for an audiovisual encounter.
Also, keep in mind, and this is not within the scope of today's webinar, but I also understand that HHS and the DEA will extend general telemedicine opportunities going into the next calendar year. So that'll basically kick over into the next administration as they interpret how telemedicine in general will be used in medical practice. And that's outside of the scope of the OTPs necessarily. So will the OTP have some policy, or can the OTP have a policy that requires some form of counseling along with maintaining the patient on either methadone or buprenorphine?
So they can have a policy to require counseling. What we want to specify is that if they have that policy, that still medication is not necessarily denied. Um, they may be able to utilize the contingency of dosing times, take homes, and such. But what we don't want is for a patient to be refused the medication or denied the medication. But they can have a policy to require it. And the most important part to that is that overcoming the barrier to why the patient is um, not compliant, not wanting to be compliant, or unable to be compliant with the counseling requirement. For instance, is it, are they working? Do they have childcare issues that are have competing scheduling requirements? Uh, those are things that, upon discussion can be overcome, um, as opposed to just strict refusal for counseling.
And that's right. And I've heard Dr. Olson say that. She said it at the beginning of our conference, which was several months ago in Las Vegas, when she said we just don't want the counseling requirement to be held like a sword of Damocles over the head of the patient. And I think the heart or the intent of the regulations is to do that. But this question comes up certainly to me when we're doing briefings for our 30 state chapters and other provider groups. And I think the issue here is, how do you then engage the patient so that there is an interest in going to counseling? And generally, I was a young clinician in the 1970s, and certainly as a director of a program in the 1980s. And there are a number of ways to engage the patient. And I think, I don't want to be too egalitarian about this, but ultimately, if the counseling is good, and if the counselor is engaging of the patient, and if the program policies are reasonable, there is little reason outside of concrete details like the patient is working and the times the counselor is available is not conducive to getting the patient in. That these are matters that have to be considered clinically within the programs. But I know that some programs are feeling that the new regulations are a bit vague on this topic. And that really goes to the issue of even how Medicaid will decide to reimburse, because keep in mind that Medicaid will say to an OTP, depending on the state's rules, if you wish to get reimbursed by Medicaid, well, counseling is a required issue. So it may not be required for SAMHSA, but when it comes to Medicaid reimbursement for the OTPs, it is required. And as you said at the beginning, if the states have more specific regulations in place, that's what the OTP has to follow. So from my point of view, the OTP has to look practically at how they get reimbursed for this service. That's just a reality.
Of course, yes.
And if Medicaid, state Medicaid is providing a reimbursement and stipulates the elements that are required to meet that reimbursement, then you have to go in that direction. But it does not mean the OTP doesn't provide counseling or the counselor in such a way that the patient is likely to be engaged. I mean, I remember when as a director, when a patient would say, but I don't want to talk to my counselor. I don't like my counselor. And, there are, practical human realities, and therefore the OTP has to make adjustments for this. So next question is, the new regs stipulate that the full physical exam must be completed within 14 calendar days following the patient admission. Does this mean that pre-discharge hospital documentation is now unacceptable for the full physical exam?
No, if that pre-hospital documentation was made within 7 days of the admission and it was reviewed by the OTP practitioner and was determined to be a full assessment, then that's okay.
Okay. The next question is, could you please define serology testing? Is that only a VDRL or exam? What are the requirements for serology testing?
So this would be, and we use the word serology, blood testing, could be for infectious diseases, viral hepatitis, HIV, certainly for syphilis as well. And anything else that the OTP practitioner determines to be important for clinical care. But infectious disease was our main focus with regard to the serology testing. But, I will state that, there are times where a basic metabolic panel might be indicated, sometimes a comprehensive metabolic panel, depending on the patient's presenting conditions and past medical history. So there is going to be some variability for individual patients with regard to what all of the testing may include. But at the very least, the infectious disease panel would be considered there.
And this is, I guess, two choices. Which of these is correct? This first, the screening and full examination may be completed via telehealth for those patients being admitted for treatment at an OTP with either buprenorphine or methadone. Or two, a full in-person physical exam, including the results of serology and other medical tests, are to be considered clinically in completing the admission.
So the question is, can both of those be true?
Yes.
So certainly the second part, if a complete exam is done with the appropriate testing and all of that is reviewed by the OTP practitioner, that certainly is something that we would consider to be adequate. I'm looking to see, was this a question in the chat?
Yes.
Okay. I'm just looking to see the first part to make sure I answer that appropriately. But can you repeat the first part again? I apologize.
Sure. No, that's fine. The screening and full examination may be completed via telehealth for those patients being admitted for treatment at the OTP with either buprenorphine or methadone.
So the screening can be completed, portions of the full assessment. The physical exam cannot necessarily be completed via telehealth. It should be done at some point within 14 days.
At the OTP?
Yes.
Okay. See, I think that, and Jim, you'll see this, and I know there will be some subsequent questions, and as we get them in, we will forward them to you. But I think that until the guidance document is released by SAMHSA, I think, and I'm saying this for the participants on this webinar, that having had the benefit of reading the draft document, recognizing there may have been some modifications, that ultimately that guidance document is extremely detailed, obviously more so than the regulations themselves. And that's simply a matter of the requirements of how federal agencies file their regulations. And that, you can't make the federal regulations a novel, obviously. And I think the narrative for the guidance document is fairly extensive. It's certainly in my reading of them, but it fills in a lot of questions, some of which were raised during this webinar. So I say this to the webinar participants, that for the time being, be patient as the guidance document is being finalized. There's been a lot of thought, and I know this given my frequent interactions with Jim and his associates at SAMHSA and CSAT, there has been a good deal of thought in going into this. And the change in regulations is designed to provide patients with greater flexibility, but OTPs with greater flexibility. So we're going to wrap up the webinar at this point.
Mark, if it's okay, I'd like to also state that these new regulations were also under the oversight of Dr. Olson, who is a current OTP practitioner, and recognizing that these regulations would be in place where she's working is an important aspect. That this isn't just some government agency determining what is right or what should be done. This is a clinician in practice still providing care for at an OTP. So there is going to be a kindred spirit as all these regulations have come out. The guidance document will be, as I mentioned, as you mentioned, it is certainly far greater in text and in detail than the regulations. But again, we're trying to do one size fits all, sitting from 10,000 feet. And this is probably going to fill in a lot more gaps.
And exactly so. And I think that, Jim, I very much appreciate the guidance you did provide today. I know that the questions will continue to raise as states go into greater alignment, as Medicaid is more activated. And I say this not just to Jim, but also to his colleagues at SAMHSA, that and dealing with CMS, that there needs to be a real encouragement, and that's an understatement, about dealing with Medicaid authorities. And that as more flexibility comes into play, that flexibility also needs to be seen in the evolution of the accreditation guidance document. In other words, the flexibility has to be fairly broad-based. Now, there is going to be a brief survey at the end of this webinar, and we're asking people to fill out the survey. It's brief. It helps guide us in the future webinar development. And we're always going to be doing this because we believe that's helpful to our field to better understand what's being expected of them. So because there are a lot of things changing, and certificates will be issued for those of you who want it, but you've got to send an email to info@atod.org if you do want a certificate of attendance. So again, thank you to the Opioid Response Network for their continued support for what we do, to Dr. Gendotra for giving us his time and expertise, and again, for all of you in our field, because we are at a time of change. And I understand that, when people get into change, there are necessarily some fears. But I do want to underscore something that Jim just said, that we do have folks over at CSAT that are very much understanding of what we're doing. They have done it. Certainly Dr. Ingvild Olsen has done it, Dr. Patty Juliana, and a number of people within their staff framework. They are cognizant of the demands and challenges that we're dealing with. And I'm absolutely convinced of this. This is not a sort of public relations statement. This is a matter of practical reality. All of this is going to take time. And if, as you have greater questions, you know how to find me, certainly. And as questions come in related to the specifics of this webinar, I promise you I will send them over to Dr. Gendotra. So thanks again. I appreciate your involvement. Do complete the survey. Jim, thank you once again for all of your guidance and your help, and we'll look forward to moving on this as the guidance document is finally released. So thanks again. And thank you. And thank you, Angelina, on our staff for organizing and managing this webinar. Obviously, it takes effort, and it also takes a lot of planning. So thanks again. Have a good day. Be well.